Hi guys, I hope I'm live and audible. So if there are any issues with the audibility, please let me know in the comment section. So today we will be learning about the management of diabetes mellitus. In the previous Reed Harrison series lesson, we have learned about the clinical features and complications of diabetes mellitus, and we are already familiar with the diagnostic criteria. So today we will understand the basics of the management of diabetes, and we will take it forward. After the basics are learned, we will go through individual drugs and the pharmacology as well, so that we are prepared for practice as well as the exams. Okay, so before we start with the management of the diabetes mellitus, let's revise one MCQ from the previous lesson. Okay, so here is the question. The question is, screening for type 2 diabetes mellitus is indicated to begin at what age for general population? Now the whole world is at risk of developing diabetes mellitus, right? It's one of the very common disease, and because especially type 2 diabetes mellitus patients tend to not have major symptoms until and unless organ dysfunction or organ injury has started. That's why screening is the main way how we recognize diabetes early. Now the question is, at what age the screening is recommended for general population? Is it at 25, 30, 35 or 45 years according to the American Diabetes Association guidelines? Dipul, welcome. Okay. So the recommendation as per ADA is that we should start screening at 35 years of age. If the screening is negative, the patient does not meet the criteria to be called as diabetic, then the screening should continue at the interval of every 3 years. Okay, every 3 years. Okay, so now with that basics, let's start with the management of diabetes. But first question is, why should we treat diabetes? Why is it a big deal? Well, in the previous class itself, you have learned why is it a big deal? Because the diabetes or chronic persistent hyperglycemia is associated with increased risk of number one, acute complications. What are the acute complications? Diabetic ketoacidosis and the hyperglycemic hyperosmolar state. So there are plenty of acute complications. There are chronic complications, and among the chronic complications, I'm particularly worried about the organ dysfunction, right? We know that diabetes is known to cause the retinopathy, nephropathy, increased risk of atherosclerotic coronary vascular disease. And in simple words, we can say that if you have diabetes, your survival is at stake. It is associated with increased mortality. It is associated with increased mortality. So if I do not intervene as a doctor, then patient will be at risk of these complications, and eventually he may not be able to live his life for the full lifespan. He may die early. Now to save him, of course, I need to get his hyperglycemia under control. Okay. Now how do I achieve? We will discuss that. But it is very clear that I have to control the hyperglycemia to reduce the risk of all the acute chronic complications and reduce the mortality risk. Now I have a question. Let us say that I have diagnosed someone with diabetes, and when he came to me, his HbA1c at the time of presentation was, let us say it was 9.2%. And I started some treatment for him. I started some treatment for him like metformin or insulin, whatever. I started some drugs. And then 3 months later, he comes back for follow-up. At this point of time, his HbA1c is 8.1%. Now tell me, how many of you would like to continue the same treatment that I had started? And how many of you want to revise the treatment? Are we on the right track? That's the question. Are we on the right track in this case? I started with the HbA1c of 9.2. I started some treatment, some medication, insulin, whatever I started. And I reassess after 3 months, and now HbA1c has dropped from 9.2 to 8.1%. Am I doing a good job here? Should I continue the same treatment? How many of you want to continue the same treatment? Ankur Nikam, yes, we are planning to run this series for long, and we will try to cover almost all the systems of medicine. Okay, now please let me know how many of you want to continue the same treatment. Is it good to continue the same treatment? The answer is, please remember, of course, there is the risk with hyperglycemia, right? Will the risk be reduced if I have HbA1c 8.1%? Yes, the risk is better than 9.2%, but it is not significantly lowered. So I can lower the risk of acute, chronic as well as mortality complications only when I achieve an HbA1c of less than 7%. So only if it becomes less than 7%, I would achieve a reasonable reduction in the risk of complications and mortality. So I have a target set. I need to reach the HbA1c of less than 7%. So should I continue the same treatment here? No. Whatever treatment improvement you're expecting, you would be expecting in a span of 3 to 6 months. If you have not achieved it, continuing with the same medications alone will not lead you to the target. It will continue to remain in the similar range. So in this case, I need to revise the treatment, right? So first thing we will agree is that when I have diabetes, I have some long-term complications, and to minimize those complications, I need to set my goals. So the first goal is HbA1c. The HbA1c, according to the American Diabetes Association, it recommends that it should be maintained at less than 7% for most individuals. Now please try to understand when I say for most of the patients. What do I mean by that? Because the treatment is always about the balance of risks of the treatment and the benefits of the treatment. Now, when I try to achieve an HbA1c of less than 7%, I may also run the risk of pushing the patients to go into hypoglycemia. And frequent hypoglycemic episodes are also associated with adverse long-term outcomes, including worsening of the neuropathy, hypoglycemia unawareness. So I don't want to take that risk. So if the patient is at risk for hypoglycemia, in such cases, the goal is to consider the HbA1c of less than 8%. But less than 8% is only for selected patients where the risk of hypoglycemia or other complications arise. Otherwise, for most patients, what is the target HbA1c? The target HbA1c is going to be less than 7%. So as long as I maintain the HbA1c less than 7%, I am doing good job. Whenever I notice that the patient's HbA1c is beyond 7%, that's the time to revise the treatment. Okay. Second, if I'm looking at the preprandial blood glucose levels, the recommendation is that try to maintain it between 80 to 130 milligrams per deciliter. That means pre-meal blood glucose, if checked, it should be between 80 to 130 milligrams per deciliter, and 2-hour postprandial blood glucose level should be maintained less than 180 milligrams per deciliter. Okay, so let me summarize. Diabetes has long-term complications, health implications. To minimize that, I need to get the blood glucose level lowered, and to how much I should lower, we have set the target. If I'm monitoring through HbA1c, I should get it below 7%. If I'm looking at preprandial, postprandial values, preprandial 80 to 130 and postprandial less than 180. Now the question is, how will I achieve these targets? What the ADA guidelines recommend, how to achieve these targets. So if I'm dealing with type 1 diabetes mellitus, we already know that these patients are at absolute insulin deficiency. So if I'm trying to treat these patients by giving some other medications which can stimulate the insulin secretion and all, it's not going to work for them because the beta cell mass is almost nil or depleted. So that's why the drug of choice, if they ask you for the type 1 diabetes mellitus, we already know it is going to be insulins. Okay. Now insulin, when I'm giving insulin, like patient is absolutely lacking insulin, I'm giving it externally, but I want to mimic the physiology. And in the previous class, I have taught you about the physiology of insulin secretion. As long as your blood glucose level is more than 70 milligrams per deciliter, pancreas continues to secrete insulin. So at any given point of time, there is always some amount of insulin in the patient's blood. So let us say that I am plotting insulin levels in the blood and time on the x-axis. Then insulin level is never going to be zero in the blood. Insulin levels will get suppressed only when patient goes into hypoglycemia and glucagon comes into picture. Otherwise, 70 plus sugar, insulin is always produced. But in between, whenever there is meal-induced hyperglycemia, insulin production also increases. So insulin level is constantly going like this. I take food, blood glucose level increases. So to counter that, insulin also spikes up. Insulin production increases, release increases, it spikes up. As the blood glucose level drops down, insulin level comes back. So this insulin value between the meals, right, we will call it as basal insulin production. This never stops as long as blood glucose level is more than 70 milligrams per deciliter, and there will be meal induced spikes. There will be meal induced surge or spikes in the insulin production. So if I want to give insulin, I have to mimic this. How can I mimic this? There are two ways. One traditionally followed way is that I can give a long acting insulin to take care of the basal insulin, and short acting or the regular insulin to take care for the meal induced spikes. So that approach is not the most preferred approach today. This approach where I give combination of insulin, where patient is getting a long acting insulin either once a day or twice a day depending on the half life of that insulin, and then short acting insulins prior to meals. This approach is called as MDI, multiple daily insulins. Multiple daily insulins, where we are combining a basal insulin plus short acting analog or a regular insulin. This is the second best approach. But what is the best approach that is currently recommended that technology offers us? I can try to mimic this same. See, here there are a lot of pitfalls. There is half-life of this basal insulin. So the level surge of this basal insulin and then it drops down. So I may not be able to perfectly mimic the normal physiology when there is half-life not mimicking the natural insulin. But what I can do is I can get an ultra short acting insulin, put it into a device, implant that device in the patient's body, and it will continuously keep releasing small amount of insulin, just like how the pancreas does to take care of the basal insulin. And then it can have a sensor mechanism to sense the blood glucose level, and appropriately it can secrete extra amount of insulin. So literally I can mimic like pancreas. So what do we call it as? We will call this as continuous subcutaneous insulin infusion. Continuous subcutaneous insulin infusion, where the device continuously keeps giving the insulin subcutaneous in the subcutaneous plane, and it can be programmed to mimic the physiology exactly. So this is a preferred approach or a first line approach. If patient cannot afford this, the next alternative is to give a basal insulin plus a short acting analog to make sure that we are closer to physiology. That is going to be our approach for type 1 diabetes mellitus. We will take some examples of cases when students present, and we will discuss how to adjust the insulin dose, how to get to the target, how to minimize the hypoglycemia risk and all. So for now, we will just take an overview. So if it is type 1, insulin is a treatment of choice. If I'm using a continuous subcutaneous insulin infusion pump, in that case, we will program it to mimic the physiology. But if this is not accessible to the patient, then I would think of giving at least 2 insulins, one to mimic the basal, that is going to be a long acting analog, and then a short acting analog to mimic the meal induced surges. Okay, now what should I do if I have a type 2 diabetes mellitus patient? In type 2 diabetes mellitus, see, type 1 we know it is an autoimmune disorder, but type 2 is primarily a lifestyle disorder. So I have to definitely fix the lifestyle along with the treatment, right? So when it comes to the management of type 2 diabetes mellitus, we have to fix their lifestyle and then think of pharmacotherapy. Now, when it comes to fixing the lifestyle, what all I need to achieve? The first thing, majority of the type 2 diabetes mellitus patients are going to be either in the overweight category or obese. So weight loss is very, very important. In fact, the body fat mass and insulin resistance have proportionate relationship. Decrease in the fat mass increases the insulin sensitivity. So thus, of course, even the glycemic control will get better. So weight loss is the first important thing when it comes to lifestyle therapy or management. The goal, how much weight the patient should lose. Should he lose the weight till he disappears into the thin air? Of course not. The goal is to have a BMI of less than 25. BMI of less than 25 kilograms per meter square. That is the weight loss goal. Now, how the patient can achieve this weight loss goal? Two things, exercise and diet comes into picture. So when it comes to exercise, what is recommended? What I personally recommend is different from what the ADA guidelines recommend. What ADA guidelines recommend is that we should recommend aerobic exercises for around 150 minutes per week. 150 minutes per week. So this can be interpreted as 30 minutes per day for 5 days a week. So patient should do some aerobic exercise like swimming, right, moderate intensity running, these 30 minutes per day, 5 days a week, and 2 days of rest. And 2 days of rest. Okay. Now what I personally recommend, if you go through more recent studies, especially from the endocrine journals, you realize that increasing the muscle mass also increases insulin sensitivity. So along with this aerobic exercise, I would personally recommend the patients to get into gym and get into some strength training. If they build a little bit of more muscle mass, it becomes even more easier to manage their diabetes. But at least bare minimum they should do is 30 minutes of aerobic exercise per day, at least 5 days a week. Okay. The next one is diet. So when it comes to diet, there are two things. If BMI is already less than 25, then I don't have to recommend them to eat less. They can eat as much as is required for their maintenance. But if the BMI is more than 25, if weight loss needed, we would recommend what we call as hypocaloric diet or calorie deficit. Hypocaloric diet or calorie deficit, where patient eats less calories than his requirement. Calorie deficit of approximately 500 kilocalories per day. So till the desired BMI is achieved, the patient should eat around 500 kilocalories lesser than his daily energy expenditure. I'm not saying lesser than BMR. So there is something called as basal metabolic rate. That is the rate at which our body burns glucose when it is not doing any major physical activity. On top of it, we do a lot of physical activities, exercise, and we burn more calories. So all put together is our total daily energy expenditure, TDEE. So whatever is the patient's total daily energy expenditure, he should eat 500 calories lesser than that, so that he keeps losing the weight till the desired BMI is reached. For those whom the weight loss is not required or desired BMI is already reached, in such cases, right? If weight loss is not required, then what I should recommend them? In such patients, they should eat their total daily energy expenditure in terms of calories, not less than that. But whatever diet that they are going to follow, their diet should be having low glycemic load, and it should be low in glycemic index. Glycemic index. From biochemistry, you study this concept of glycemic index. In simple words, what glycemic index of a food means: how quickly the carbohydrates from the food can be digested and absorbed into circulation. More simple the carbohydrate it is, like for example sugar, it will have high glycemic index, so it will be easily digested, quickly absorbed into the blood, and the blood glucose level will quickly spike. So you have to avoid such food items. So in simple words, I would say avoid the processed food items, which mainly contains maida and sugar, right? All these processed. Eat as much natural as possible, especially the food which carries complex carbohydrates, which takes its own due time to digest and increase the blood glucose level, are acceptable. So of course we can find or hand over a list of low GI food items which patients can incorporate in their diet. That's not the only thing. What if I eat truckload of low GI food items? Still my blood sugar will spike significantly, right? So even the load, when I say glycemic load, in simple words, we're talking about the quantity of carbohydrates in the food. The quantity of carbohydrates in the food should be reasonably lowered, and whatever carb sources we are choosing should be having low glycemic index. So these are our basic lifestyle modifications. Aim a BMI of less than 25. To achieve that, at least 30 minutes of aerobic exercises per day and some calorie deficits. If your BMI is already low, then still continue with aerobic exercises. You can eat your daily calorie expenditure, but make sure that the carbohydrate load is less in your food, and your food primarily comprises of the low GI carbs and not the high GI carbs. Okay, now after this lifestyle therapy, we have to also think about pharmacotherapy. In the last 7 to 8 years, the management of diabetes has seen a sea change. Earlier, what we used to do, especially when I was an undergraduate student, diabetes means type 2 diabetes. I'm talking about type 1 is anyway insulin from the beginning. But if it was type 2, how we used to treat? First, we start with metformin, follow up, not controlled. Then we used to add sulfonylureas, not controlled. Then we got some newer class of drugs like DPP4 inhibitors and all. All of them were good drugs. They helped in reducing the HbA1c, better glycemic control, and long-term reduction of complication risk. But then over last few years, we started noticing that some class of drugs were more efficient in reducing the risk of complications than the other class. Just to give you an example, if I take a class of drugs called as sulfonylureas and a class of drugs called as SGLT2 inhibitors, right? Let us compare these two, sulfonylureas and SGLT2 inhibitors. Let us say I am treating patients with these drugs. Both of them had an HbA1c of 10 to start with. Okay, let me keep it 9. 9 to start with. And I started sulfonylurea. And then follow up, repeat HbA1c over a few years. I achieved, in case of sulfonylurea, let us say I achieved HbA1c of 8. And SGLT2 inhibitors also I achieved HbA1c of 8. Proportionately, both of them will have reduction in the risk of complications. Not the perfect reduction that or the best possible reduction in the risk of complication that I can achieve. That I will achieve only when I get a HbA1c of less than 7. That I have already told you. But some reduction is possible. That reduction, both of them started with same HbA1c, both of them ended with same HbA1c, but the risk reduction is not similar. These patients who were started on this SGLT2 inhibitors, they had much more reduction in the risk of cardiovascular diseases, the renal diabetic nephropathy or renal failure, heart failure. All the risks were significantly lowered in this group of patients who were receiving SGLT2 inhibitors than those patients who were receiving sulfonylureas. So it is no longer about only the HbA1c. It's also about mitigating the risk and getting the complication risk minimized as much as possible. So we need to make now wiser choices. It's not like before anymore. So what current guidelines recommend? Once you have a type 2 diabetes mellitus, for every patient implement the lifestyle treatment, and then metformin, if not contraindicated, can be considered for all patients. Okay. Can you name some contraindications for metformin therapy? Some contraindications for metformin therapy. Are there any major contraindications for metformin, or is metformin known to cause any complications? Well, so please remember, metformin is one of the wonder drugs when it comes to management of diabetes, because it increases the insulin sensitivity, or in other words, reduces the insulin resistance, which is the root cause for type 2 diabetes mellitus. So we are hitting the root of the problem. But metformin is known to cause lactic acidosis, and this risk of lactic acidosis is higher in patients with compromised kidney functions, because maintaining the acid base balance, kidneys play a very, very important role. It is known to cause lactic acidosis, and the risk is high in end stage renal disease. So patients with the end stage renal disease with very low GFR, especially less than 30, they may not be able to tolerate metformin. They will end up with lactic acidosis. So it is contraindicated in that case. If patients have lactic acidosis because of some other cause, already it is contraindicated. Patients may not tolerate. If patient is not tolerating metformin, many patients have severe nausea, vomiting, and GI disturbances. They may not be able to tolerate. In some individuals, it is known to cause, especially long-term use of metformin is known to cause B12 deficiency. So there are issues with metformin as such. So if there are no contraindications, patient is tolerating well, start metformin for all type 2 diabetes mellitus patients. But that alone is not enough today. In the past years, that would be more than enough to start. Only when not controlled, we would think of adding other drugs. But today we prefer to treat not with metformin alone, but with additional drugs. But what will be that additional drug? That choice depends on other comorbidities or other factors. For example, if patient is having atherosclerotic coronary vascular disease, means he has coronary artery disease, he has ischemic heart disease, or he has high risk of atherosclerotic coronary vascular disease. Now, who is high risk? Who is having high risk of atherosclerotic coronary vascular disease? Raman, I'll get it done. Anyone who has family history of IHD with early death or young death, death before 40, 50 or even 60 years of age because of ischemic heart disease. Anyone who is having additional risk factors for coronary vascular disease like hypertension, dyslipidemia, massive obesity, right? So these are all considered at high risk for atherosclerotic coronary vascular disease. In them, not only reducing the blood glucose level, but I also want to minimize the risk of developing or progressing the coronary artery disease. So are there any class of drugs which not only lower the glucose levels but also protect the heart from developing these complications because of diabetes? So last 7-8 years, we came to know that there are classes of drugs which not only reduce the HbA1c, but they also reduce the cardiovascular mortality risk, which is beyond what we can expect with HbA1c. Like I gave you an example, sulfonylureas and SGLT2 inhibitors both lowered the HbA1c same percent, but SGLT2 inhibitors reduce the complication risk more, right? So similarly, if I'm using two drugs like sulfonylureas plus the new class of drugs, there are new class of drugs which can reduce the mortality many-fold in comparison to the mortality reduction that I can achieve by merely reducing the HbA1c. So what class of drugs are having proven benefits? The first one is GLP-1 analogs. GLP-1 analogs. Can anybody give me the examples for GLP-1 analogs? Examples for GLP-1 analogs. GLP-1 analogs. So the first one that when I was preparing for my exams that came into the market was liraglutide. Now we have even more effective drugs, semaglutide, tirzepatide, in fact, very recently I had to, I got into a conflict with one of the gym trainer, very famous on social media, who was talking against these drugs. He's saying that instead of these drugs, patient ko, they should go through more natural remedies. These drugs are harmful, they make you look sick. No modern medicine claims to be free of side effects. These drugs also have their own pitfalls, their own set of side effects. But when used in the right context for the right person, they do wonders. They reduce the HbA1c, they reduce the complication risk, and they reduce the cardiovascular mortality, not just the HbA1c, right? Yes, dulaglutide, liraglutide. So now what guidelines recommend is that once you have type 2 diabetes mellitus, if the patient is having atherosclerotic coronary vascular disease or is at risk of it, not just stick to metformin. In addition to metformin, add GLP-1 analogs. Or if GLP-1 analogs are of course expensive, if they are not an option, then even SGLT2 inhibitors like dapagliflozin, empagliflozin, they are also known to decrease the cardiovascular mortality risk. So now the best treatment if patient has IHD or IHD risk, metformin plus one of the GLP-1 analog or one of the SGLT2 inhibitor. That's the approach. So what benefit the patient gets is control in the glycemic parameters that we wanted to achieve. Along with that, further extra reduction in the risk of progression of heart disease or development of heart disease. Okay. Now similarly, if patient has got diabetic, yes, canagliflozin, dapagliflozin, empagliflozin, studies have proven their cardiovascular mortality benefit. In fact, right now, the use of SGLT2 inhibitors is recommended even in the absence of diabetes for the patients with ischemic heart disease and heart failure because they don't cause hypoglycemia and they give the mortality benefit. Okay. Now, second, What if patient has got CKD, or in other words, he has developed diabetic nephropathy, which will progress eventually to reach what we call as end stage renal disease, mandating the transplantation of the kidney, or at least patients should land upon dialysis. So is there any medication which not only lowers the blood glucose level but slows down the progression of diabetic nephropathy towards the end stage renal disease? So once we have diabetic nephropathy, initially patient will be not symptomatic. He will only have proteinuria or albuminuria. But over time, what happens? This will progress because the GFR goes on decreasing. The GFR goes on decreasing, and eventually he will reach a stage where we will call it as end stage renal disease. And that point of time, I have to manage them with either transplant or dialysis. So by controlling the blood glucose level, of course, I can slow down the progression, but I want to slow down further, not only the benefit that I get by controlling the blood glucose level. So is there any class of drugs which can give an extra added benefit of slowing down the disease progression? Yes, that is going to be SGLT2 inhibitors. So if you have a patient with diabetes and CKD, of course, metformin may be contraindicated if the GFR is very low. If GFR is fair, a reduced dose of metformin can be given. And in addition to that, you should consider adding an SGLT2 inhibitor, Okay. Similarly, a diabetic patient who is having heart failure, that said heart failure with either preserved ejection fraction or heart failure with reduced ejection fraction, both. In the past, we used to only push this recommendation for heart failure with reduced EF. Now just heart failure with preserved or reduced ejection fraction. If there is type 2 diabetes with heart failure, adding SGLT2 inhibitors is known to reduce their risk of heart failure progression, risk of exacerbation of heart failure, need for admission with worsening heart failure. All of that will come down if I add SGLT2 inhibitors. In fact, if you think of the heart failure, even in non-diabetic patients, SGLT2 inhibitors are today recommended because they are known to reduce the cardiovascular mortality in heart failure patients. Clear? So metformin plus SGLT2 inhibitors, metformin plus GLP-1 analogs or SGLT2 inhibitors in this case, SGLT2 inhibitors in CKD case. Now, another set of patients may require weight loss. Like we were talking about, we have a target BMI of less than 25. Those who are above this, we not only have to achieve glycemic control and HbA1c of less than 7%, but I also have to achieve weight loss. So are there class of drugs which assist in weight loss? Yes. What drugs can assist in weight loss? In fact, now this class of drugs are very popular on the social media for their weight loss benefits. Yes. So in such cases where weight management is required, what is recommended? In addition to metformin, you can consider adding, in these cases, you can consider adding GLP-1 analogs. GLP-1 analogs. Again, the older generation GLP-1 analogs like liraglutide and dulaglutide are relatively less effective. What is more effective? The newer generation of GLP-1 analogs. The examples I can quote is like tirzepatide and semaglutide. Tirzepatide and semaglutide. So both of them will definitely reduce the HbA1c by 1 to 1.5%. In addition to that, 16 to 70% reduction in the overall cardiovascular mortality with this class of drugs, GLP-1 analogs. Here they are useful. And in addition to that, they will also help you lose weight. So patients have lost even like literally 8 to 12% of body weight over few months. So these are all additional considerations we have to take when we think of management of type 2 diabetes mellitus. Now, it is all similar to what was there in 2024. The guidelines have not changed much, but one change has happened in 2025. What is that change? There was a new change because now we recognize that liver is a crucial part of this whole metabolism. And now we also understand that development of fatty liver increases your risk of developing insulin resistance and thus type 2 diabetes mellitus. And addressing the fatty liver also reduces the insulin resistance and helps you achieve a better glycemic control. So if I have a patient of type 2 diabetes mellitus where he has this non-alcoholic fatty liver disease, is there anything else I can do for the patient? So just like how we had these concerns for the patients with the diabetes, where we had to think of coronary artery disease, CKD, heart failure, or weight. Similarly, now we have to also think of one additional concern in any patient, that is mass LD. What is mass LD? It's a new term for the NAFLD. All of you are familiar with NAFLD, that is non-alcoholic fatty liver disease. We no longer call it as non-alcoholic fatty liver disease. We call it as mass LD, which stands for metabolism associated liver disease. Metabolism associated liver disease. So it's insulin resistance leading to more fat accumulation in the liver, more fat accumulation in the liver leading to worsening insulin resistance. It's a spectrum. Okay. Now, in such patients, in fact, any patient with the NAFLD, one of the effective treatment is to lose weight. You lose weight, you lose fat from other body parts, also from the liver. At least in the initial stages, it's perfectly reversible. So those drugs which can help me to lose weight will give me an extra benefit here, right? So which drugs can help me to lose weight? GLP-1 analogs. Preferably, we will use those drugs which also stimulate GIP. So GLP-1 analogs can be used in such patients as in addition to metformin, but I would prefer using tirzepatide. Why tirzepatide? This is not just a stimulant for the GLP-1. This is combined GIP, gastric inhibitory peptide, plus GLP-1 stimulant. That gives an extra metabolic benefit in patients with MASLD. So just like how if I have heart failure, you would consider SGLT2 inhibitors, for coronary artery disease, GLP-1 analogs or SGLT2 inhibitors. Similarly, for a patient with NAFLD, you should consider adding a GLP-1 analog, preferably a combined analog if a patient has NAFLD. But what if the liver disease has already progressed to what we call as steatohepatitis, means inflammation of the liver has started happening. Only fat is NAFLD, but fat in the liver has caused cellular damage and triggered an inflammation. Then we call it as MASH. So if there is MASH, what I should consider adding? So if there is MASH, again, I can consider adding the GIP plus GLP-1 analog like tirzepatide. And in addition, there is also another drug which is known to be effective in fatty liver disease and MASH, and that is going to be pioglitazone. So this is going to be our initial treatment for a type 2 diabetes mellitus. Now you may be wondering, sir, in pharmacology we studied so many other class of drugs like sulfonylureas and all. Why are we not talking about it? Sulfonylureas were good in reducing the blood glucose level, reducing the HbA1c, but they had their own set of problems. What problems I would face if I am dealing with sulfonylureas as the treatment for type 2 diabetes mellitus? Sulfonylureas are insulin secretagogues. So what do? They stimulate insulin production by the pancreatic beta cells. So by doing so, of course, they reduce the blood glucose level. But how insulin is actually going to reduce your blood glucose level? Because blood glucose level is through insulin here. How insulin reduces? Simple. Glycogen, like generation of more glycogen and formation of more fat. So basically your blood glucose level is converted to fat and glycogen by insulin. So in that case, what happens? There is increase. This insulin leads to increased adipose mass or increased fat mass in the body. So that will lead to weight gain. So sulfonylureas were well known to cause weight gain. If you start sulfonylureas, patients start gaining weight. Second, this will also associated with worsening increased insulin resistance. Because more the fat mass, more is the insulin resistance. Other problem, because they're stimulating the pancreatic beta cells to secrete the insulin. The hyperstimulation of beta cells cause more damage to the beta cells, and this will result in decreasing beta cell mass. So number of beta cells will go on decreasing. Insulin resistance will go on increasing. Insulin resistance is increasing, beta cells are decreasing, patient is gaining weight. So we are getting some glycemic control. We are minimizing some complications related to the hyperglycemia, but we are making the diabetes progress faster with all these changes. So they were not the great drugs. So today we have better drugs. So we generally do not prefer to consider sulfonylureas as the mainstay of treatment when it comes to type 2 diabetes mellitus. But yes, you may say, sir, I see plenty of prescriptions of sulfonylureas even today. Why no doctor, or why most of the doctors are not following these more modernized approaches? So please remember why most of the doctors are not following this. It's because our socio-economic status is different from rest of the world. We still have poverty lurching in our country, right? Still taking out 5,000, 6,000 rupees a month for their diabetes care is out of reach for most of the people. Sulfonylurea is a cost-effective drug. If I can't use these drugs, and if I just give up on treating, like I'll stick to metformin and not treat at all, of course, that's not the best thing, right? So in that case, despite knowing that the diabetes will progress faster under the influence of sulfonylureas, at least I can minimize the complications to some extent arising out of hyperglycemia with the use of sulfonylureas. But as the economy improves and I start seeing more affordable patients, I would prefer to use these newer class of drugs, because they not only reduce the glucose level, give you extra benefits of weight loss or cardiovascular mortality reduction. These achieve glycemic control, but actually increase the risk of some complication. In fact, sulfonylureas are known to increase the risk of cardiovascular mortality as well, right? Now comes the question, what if I started these medications, but I'm not able to achieve my target HbA1c, which is less than 7%. In that case, you can start with the insulin therapy. Okay. Now, sometimes this is again a common argument that I get from the students. They have learned that insulin therapy comes into picture in the management of type 2 diabetes mellitus after we have gone through all this metformin, SGLT2 inhibitors, GLP-1 analogs, and then insulin comes into picture. But they say, sir, doctor directly started me on insulin. So, or started this particular person on insulin. Is he doing the right thing or not? It is not a type 1 diabetes. Type 1 ke liye to of course we have to start insulin from the beginning. But for type 2, what? Why is he starting insulin directly? There are certain indications where we have to start the insulin from the beginning itself. Early initiation of insulin. When is it recommended? So the first thing, the most important thing that I want you to remember, where please do not waste time trying oral hypoglycemic agents to control the diabetes. Directly start the insulin. What is that? Anyone with a catabolic state or severe symptomatic type 2 DM. Now, what do I mean by catabolic state? Anyone who is having diabetes and losing weight rapidly. That's a catabolism, breaking down your tissues. Or if he is having severe symptomatic DM, means severe polyuria, polyphagia, polydipsia. So that's why in simple words, you would say that anyone who came to me with symptoms of diabetes, that polyuria, polyphagia, polydipsia, I should start him on insulin first. If I find out someone is diabetic on screening, then insulin should not come into the picture first, right? Okay, so what are these symptoms that we are talking about? Polyuria, polyphagia, polydipsia, and weight loss. Polyuria, polydipsia. I'm not writing the polyphagia here because polyphagia as an isolated symptom should not be taken as a symptom of diabetes. Otherwise, we are very much fond of eating. All of our patients, especially diabetes, are very much fond of eating. So they will keep complaining of increased appetite. But if they're having polyuria, polydipsia, or if they have weight loss, then we have to start them on insulin. This is where I face challenge. Like as a physician, when I want to initiate insulin for these patients, they have a fear that should I or will I be insulin dependent throughout my life? The answer is no. We are initiating the insulin, but once we have achieved a reasonable glycemic control, we can make an attempt. I'm not promising to the patient that I will be able to stop insulin and switch you to the oral hypoglycemic agents, but we can make an attempt to switch them to the oral hypoglycemic agents. Please don't think that in type 2 diabetes mellitus, if insulin is started once, it is for life. Only for type 1, it has to be started on the day of diagnosis, and then it is for the rest of the life. Okay, then the second indication to start early insulin is when your random blood sugar or random blood glucose is more than 300 milligrams per deciliter. More than 300 milligrams per deciliter. Jeevanpat, you can drop your reports, everything to me on the Telegram, and I'll connect with you. We will figure out what to do for you. Okay. So RBS more than 300 milligrams per deciliter is the second indication. The third one is HbA1c of more than 10%. HbA1c of more than 10%. If someone's HbA1c is more than 10%, don't try to treat them with this approach. Start the insulin, lower the HbA1c under 10%, and then get back to this approach. Okay. Then there is a fourth indication. Any patients presenting with hyperglycemic crisis, means acute complications of hyperglycemia. Hyperglycemic crisis. What is hyperglycemic crisis? Either patient present with a diabetic ketoacidosis or hyperosmolar hyperglycemic state or HHS. So these four circumstances, we will initiate the insulin early. But as I've already told you, initiation does not mean that the insulin will be the lifelong treatment. If glycemic targets are achieved, we can consider switching to oral hypoglycemic agent, right? So this is going to be our approach to the management of diabetes. This is not a detailed pharmacological discussion. In the next class, we will take up the pharmacology of especially the important class of drugs like the metformin, sulfonylureas, SGLT2 inhibitors, GLP-1 analogs. We will study about individual drugs, how to monitor the side effects of those drugs, what side effects are anticipated, and the long-term management as well. Okay. So that's the summary of the today's discussion. We will quickly go through a question before we wind up from today. Okay. So what we have learned today, we have learned that diabetes is associated with long-term complications. To minimize the complications, I need to have a tight glycemic control, HbA1c of less than 7%, preprandial 80 to 30 or postprandial less than 180. I can try to achieve this in type 1 diabetic with the help of insulin, preferably continuous subcutaneous insulin infusion. If that's not possible, multiple daily insulin injections where I'm mixing basal and the short-acting insulins. For type 2 diabetes mellitus, lifestyle modification is a very crucial thing. So it should start with the weight management, aerobic exercise, and appropriate diet. And then when it comes to pharmacotherapy, metformin if there are no contraindications. And in addition to that, based on what other goals I need to achieve in this patient, if there is coronary artery disease or CKD, heart failure, or even weight issue or fatty liver issue, in all such cases, we will make an additional consideration of a drug which is proven to be beneficial in that circumstance. Okay. And after that, we just learned that for some subset of patients, we have to start the insulin early. Otherwise, most other patients, we are reaching to insulin after the initial management has failed to achieve the target HbA1c of 7%, then we go to insulin. But if patient presents with a random blood glucose of 300 plus, or if he is in a catabolic state or is having polyuria, polydipsia, weight loss, or HbA1c of more than 10%, or if he presents with DKA or HSS, we have to start them on insulin. Okay, so we'll take one MCQ and then we'll connect in the next class to discuss the pharmacology of these drugs. So here is a question. We have a 48-year-old male with HbA1c of 8% and he is having polyuria, polydipsia, polyphagia, and his BMI is 28 kg per meter square. Which of the following is ideal initial treatment for this patient? Options are metformin, dapagliflozin, metformin plus tirzepatide, and insulin therapy. So what do you think we should be starting here? So this is our question. Please look at the patient's HbA1c, other parameters given, age, and then what should I be starting him on? We've just discussed the basics, so try to answer this now. What do you think should I be starting for this case? Should I start metformin alone? As I've already told you, today metformin should be given for all patients of type 2 diabetes mellitus, but not alone, right? So then what I should do? Okay, Arjun, very good. So here, HbA1c wise, I don't need to push myself to start insulin, but he's having polyuria, polyphagia, polydipsia. So keeping that in mind, I need to consider this patient on starting insulin. That's what I discussed in the previous slide, right? Anyone who has this symptomatic type 2 diabetes mellitus or is in catabolic state, we should start them on insulin. So this patient needs insulin. He should be started on insulin. Okay, I forgot to mention. So this, let us say that we are dealing with a type 2 diabetes mellitus patient. Of course, if I'd said type 1, anyway, you would have still gone with insulin as the answer. Now let me see how many of you get the next point right. Okay, the same patient, I started him on insulin therapy. His symptoms have disappeared. HbA1c has dropped down to, let us say, 6%. From 8, it has gone to 6%, and no more 3 P's of diabetes. No polyuria, polyphagia, polydipsia. So he is now settled. Okay, and now patient wants you to consider oral agents, and he no longer wants to take insulin. And as I've already told you, we can definitely consider that. Okay, so if I have to now switch him to the other class of drugs away from insulin, in that circumstance, what option will you choose? What option will you choose? Yes. In that case, option B becomes the answer. So the simple take-home message is that when they are in a critical state, when they are symptomatic, see, anyone with polyuria, polydipsia, with diabetes, we have to take it as symptomatic diabetes mellitus. So if they're symptomatic, we have to start insulin first. Once the symptoms resolve, then we can switch to other drugs. When we are switching to other drugs, other extra factors will be taken into account. So in this case, BMI is high. So weight management is required. So when weight management is required, what our algorithm tells? When weight management is required, we prefer to consider GLP-1 analogs in addition to metformin. So that's why option B becomes the right answer. Option B becomes the right answer in the second scenario that I told, right? So this is how we are going to initiate the management of diabetes mellitus. Now that we are familiar, we will wind up today. In the next class, we will go through the pharmacology of all these individual class of drugs, and then we will start taking up the cases on diabetes mellitus. And then eventually one more class, we will discuss about the DKA and HHS as complications, and then we will move to the next topic, right? So that's it from me today, and I'm signing off. And I had to reschedule the class because I'm very sure majority of you are also curious to watch the IPL match. So I relieve you now for the IPL, and I hope this time, of course not hope, this time one of the two teams which had never held the cup will hold the cup. May the best team win. Okay, so see you in the next class on 6th. Till then, have a good time. Bye bye.